Thanks, Joe. So my disclosures are the same. We're going to talk now about diagnosing ventricular arrhythmias, then we're going to talk about management, then we're going to get into devices. And the reason I've added devices the last couple of years is simply because you deal with them every day. I walk into our intensive care units, and it looks to me like in our cardiac intensive care unit, everybody has a device. Even when I walk into our surgical intensive care unit and our general medical intensive care unit, it's more and more common for me to see pacing spikes all over the place, and people have defibrillators. And if you deal with people who are sick and you deal with elderly patients with heart disease, you're going to see people with devices, so you have to have a systematic approach. So let's talk about wide complex tachycardias. How do we know it's ventricular tachycardia? And there's a couple of rules. People will go all these complex ECG rules, what's the direction of the R prime and V1 and the ratio of R to S and this, and I can never remember those rules. So I go with fairly simple rules. It's likely to be a supraventricular rhythm if it's irregularly irregular. If you have a classic left bundle or right bundle branch block, now that's assuming that you recognize what a classic left bundle or right bundle is. If you look at the normal cardiogram and the QRS is either the same or it's just wider, it's probably a supraventricular arrhythmia. Supraventricular arrhythmias are more common in people with structural heart disease. So if you don't have a history of heart disease, think supraventricular. And obviously, if you have a history of another supraventricular arrhythmia and you develop a wide complex rhythm, it's probably going to be that. For ventricular arrhythmias, well, do you have structural heart disease, and does it affect the ventricle? If it does, then it's likely to be a ventricular rhythm. Most ventricular tachycardia, at least stable ventricular tachycardias, are regular except for fusion beats. AV dissociation is what you want to look for. So you're always looking, are there dissociated P waves? And then the one ECG thing that I find helpful is if you have extreme left axis deviation. So if your QRS axis is minus 60 to minus 180, and it isn't that at baseline, that's more common with ventricular rhythms. Now, I would caution you about the use of adenosine. A lot of people still use adenosine for diagnostic purposes, and it's not without a price. If you use adenosine, things can happen. You can get atrial premature beats and ventricular premature beats. Adenosine facilitates atrial fibrillation. It also shortens the refractory period of accessory pathways. So if you do have somebody who has an accessory pathway and you give them adenosine and you give them an atrial fibrillation, you can get into trouble. You also, if you produce heart block, there's a secondary effect where you get sinus tachycardia and increased conduction. So if you give it to somebody in flutter, you may bring out the flutter waves, but then you may go one-to-one. You can get long pauses, and if you get long pauses, you can get bradycardia-dependent polymorphic VT. So I'm not saying don't use it, it's just know what can happen and be prepared for it. This just shows you adenosine used in somebody with pre-excitation. We're in the EP lab here. These are intracardiac recordings. This is a blood pressure. We've terminated the tachycardia over here off the screen. We're now pre-excited, but then we go into atrial fibrillation. Adenosine shortens the atrial action potential and facilitates this. If this patient had rapid conduction over the accessory pathway, we may be going 300 beats a minute over here. It's actually interesting that about 10 years ago, Fred Marati's group at the University of Michigan looked up, who uses adenosine? And, for full disclosure, the University of Virginia used to own the patent for adenosine, so we were very happy that people were using it a lot inappropriately. About 75% of the use of in-hospital adenosine was for non-labeled indications, and people would use it all the time to diagnose tachycardias that they didn't know what they were likely to be, even though it wasn't likely to respond. So you can use it, but you have to know you can get bad things, and you just don't use it indiscriminately. If you can make the diagnosis on the cardiogram, don't use adenosine. So how do we diagnose ventricular tachycardia? Well, the ECG shows a bizarre QRS. Now, the QRS is usually wide, But increasingly, we see narrow QRSs, even though it's a ventricular rhythm. So you have to be careful. The rates are 100 to 290. Usually it's regular or have minor irregularities. AV dissociation, where the P waves and the QRS don't have a fixed relationship, is seen in about 50%, but you can't always see that on the surface cardiogram, or it's very difficult. One of the things you have is if you have AV dissociation, you can get fusion beats, but you only see that at slower rates, and you only see that if you have AV dissociation. In evaluating ventricular tachycardia, I have one of my referring doctors, who I hope isn't here today, who will give me a call, and he says that he has a patient with V-tachy. And I just have learned to take the referral, and because I don't know whether he means whether it's sustained or non-sustained, whether it's monomorphic or polymorphic, whether it's an accelerated ventricular rhythm or a reentrant rhythm. He just knows it's V-tachy, and he sends the patient, and we deal with it from there. But all these things make differences in how you approach the arrhythmia. For example, this is a ventricular tachycardia. However, the characteristics of it are that it's what we call an accelerated ventricular rhythm. It's an automatic rhythm. It usually has a very benign prognosis, almost never goes above 150 beats per minute, but the surface cardiogram, you'd have to call it as a ventricular tachycardia. You can also use the cardiogram to diagnose where the rhythm is coming from. Here, for example, is somebody with ventricular tachycardia. It's a wide, complex, regular tachycardia. If you look carefully, you can see there are dissociated P waves. I've labeled two of them for you here in lead V1. We can say that it has a left bundle type pattern, and it's upright in the inferior leads, 2, 3 AVF, and it's negative in 1 and L. So this is a tachycardia from the septal border of the right ventricular outflow tract in most cases, not all, but in most, and we can then be pretty sure of how to approach this particular rhythm. It's also important to know that you can get the same cardiogram in different substrates and then require different therapies. Here's just an example. Most of the time we think of post-MI coronary disease. But remember, dilated cardiomyopathies, hypertrophic cardiomyopathies, infiltrative diseases like sarcoidosis and Chagas disease, RV dysplasia or a specialized right ventricular cardiomyopathy, repolarization abnormalities like long QT syndrome or Brugada syndrome, a whole bunch of other genetic syndromes that predispose you to arrhythmias, Wolff-Parkinson-White syndrome, and then some people where we say it's idiopathic because we don't know where they are, and the rhythms can come from either the right ventricle or the left ventricle. You can have the same looking cardiogram and require totally different approaches to therapy depending on what the underlying substrate is. So when someone says, I want you to give you a literature on V-tach, I say, okay, V-tach in normal hearts, structural hearts, dilated cardiomyopathies, or what? They're all different. You can't have rules that apply to all of them. Okay, how do we stop VT? Somebody walks into the emergency room or is in the intensive care unit. They're in a wide complex tachycardia. What do you do? Well, obviously, you follow the ACLS guidelines, and as you'll see, the ACLS guidelines, if in doubt, shock. You know, somebody who's unstable, shock, deal with it later. But if you want to use drugs, the old days we used to use lidocaine, and lidocaine, I tell people, is great for starting the IV, takes the pain away, you know, the patient doesn't feel the catheter going in, but it's almost ineffective for breaking VT. Procainamide is effective, but is dangerous. This study actually just showed that if you use lidocaine, about 20% of people would respond, but if you use procainamide, up to 80% of people would respond. Well, in certain textbooks and in Europe, they therefore recommend that procainamide, IV, you can't get it orally anymore, but IV be the treatment of choice. You have to give it rapidly. If you give it slowly, you'll slow the tachycardia, you'll drop the blood pressure, but you usually won't terminate it. So you have to sit there at the bedside and push it, and you can break most cases of hemodynamically stable VT. If they're not hemodynamically stable, you have to shock them. You'll notice in the ACLS guidelines that amiodarone is listed as the first option. And why is that? Well, it's not because it works. This is a study from the emergency room, Mass General. looking at people who presented with monomorphic ventricular tachycardia. They put 21 people on amiodarone. They got termination in only 5, which is about what you get with nothing. And they made some people worse. And if they gave it on top of another drug, they also didn't terminate people, only about 20%. And it takes a long time. The reason why it's in the guidelines, and this is the wide complex tachycardia algorithm, you can see amiodarone is right there. It's pretty safe, and if you can wait 24 hours, it probably will work, or may work. And so that's why it's in the guidelines. Procanamide lowers the blood pressure. You have to monitor it very carefully. But if you really want to break somebody in the next 20 minutes, you want to use procanamide. So it's one of those things where the guidelines and what works aren't always in agreement. If somebody has sustained monomorphic VT, remember that you can't use hemodynamic stability to diagnose an arrhythmia. The hemodynamic stability depends on rate and the patient factors. The troponin almost always goes up in VT or cardiac arrest, so you can't say that it's an ischemic event just because the troponin went up. In fact, ischemic arrhythmias are usually not monomorphic VT. So if you see a monomorphic VT, it means the patient either had a prior scar or it's an accelerated ventricular rhythm, which has a different connotation. So if somebody has monomorphic VT, you don't have to look for infarction. You have to characterize their heart disease, but you don't have to acutely cath them. Verapamil and diltiazem are calcium channel blockers. They can really make things worse. So for wide complex tachycardia, unless you're definitely sure of the rhythm, don't use these drugs. Adenosine, I think, is overused. It's sometimes helpful. And remember, synchronized cardioversion or ICD therapies are really useful options. Why do we ever use amiodarone for acute management of arrhythmias? Well, there are 2 studies. The ARREST study comparing amiodarone to placebo, showing that there was a better return of spontaneous circulation in people treated with amiodarone than in people who were treated with placebo. And amiodarone was also compared to lidocaine in the ALIVE trial and showed that there was better return of spontaneous circulation, return of spontaneous circulation on amiodarone than on lidocaine. In both of these studies, amiodarone was given very late in the cardiac arrest. So transcribing that to the in-hospital situation where we respond pretty early to cardiac arrest may not be accurate. In this setting, as you can see, more people got to the hospital and had spontaneous circulation, but unfortunately not a significantly number survived to hospital discharge. So amiodarone is in the ACLS cardiac arrest guidelines. It's in there because it's probably the only drug that's been antiarrhythmic drug that's been systematically studied in cardiac arrest. It does have some benefit, but don't expect a lot out of it. Now, that's monomorphic VT. We've talked a little bit about cardiac arrest. What about polymorphic VT? Well, here we have a bizarre and variable QRS morphology, and the rates are highly variable. Sometimes you have very slow rates at about 150 beats per minute. Sometimes they're greater than 300. And the key here is recognizing the syndrome and putting it together with other factors. That's why, because there are mechanisms, some of them can be multiple reentry circuits, and the other ones are early after depolarizations, which are both bradycardia dependent and bradycardia independent. And the etiologies are diffuse. Repolarization abnormalities, both that lead to long QT intervals, whether they're congenital or acquired, especially if they're drug-induced. Severe bradycardia leads to this. Ischemia is probably the most common cause, particularly for the non-bradycardia dependent ones. But other things, hypertrophy, heart failure, metabolic disturbance, any critical illness can give rise to polymorphic arrhythmias. This is in the situation where you have repolarization abnormalities like long QT intervals. The theory is that what we get is early after depolarization, so that the action potential never fully recovers. You get oscillations, and if the oscillations, which are called early after depolarizations, are sustained, you get this type of rhythm, and we call it torsade de Pont, the turning of the electrocardiogram and the twisting. This can either be sustained or go on to ventricular fibrillation. It's a very malignant rhythm, and you have to recognize it. We worry about it because many of our drugs cause it, both cardiac drugs and non-cardiac drugs. We're converting people with abutolide, for example, after atrial fibrillation. We often get QT prolongations. A PVC occurs here. Here's a classic example of Torsade. Fortunately, this one stopped, but it's something that's the reason why we monitor people when we start them on drugs that prolong the QT interval. The problem is that we use drugs that prolong the QT interval to treat this rhythm, which looks exactly the same. Here's something with a severe ischemia, and we get polymorphic VT or Torsade. We would probably use a drug like amiodarone to treat this, whereas on the previous slide, we'd certainly try to avoid the use of a drug that prolonged the QT interval. So it's really critical when you see polymorphic VT to think, why is it occurring? What's the etiology? Is it associated with bradycardia? Because I can treat bradycardia. I can increase the rate by isoproterenol or pacing. I can look for drugs that prolong the QT interval. Magnesium is a specific suppressant of early after depolarization, so I can give magnesium even if the serum magnesium is normal. Potassium, low potassium, facilitates it, so I can give potassium, and if there's ischemia, I want to treat it. If it's bradycardia independent, it's likely due to ischemia, but we do use other antiarrhythmic drugs, class 3 drugs most commonly. Certainly beta blockers also have to be considered. You also have to think that the mechanism for death in heart block is not asystole. So in severe bradycardia, here's somebody in either 2-to-1 heart block or complete heart block. You can see that they go there, they have a long pause, and then they go into Torsade. And if we had monitors in the 1940s before we had pacemakers, this is how people with complete heart block die. They don't just go asystolic usually. This is it. Eventually you'll have one of these that just keeps going. So again, if you see this, the treatment is not treating the ventricular rhythm. The treatment is treat the heart block and reverse the situation. Here's somebody with a really long QT interval and ugly looking T waves. They're inverted all over the precordium and the inferior leads. Well, what's causing this? Long QT syndrome? Well, this person was 79 and had been asymptomatic. CNS lesions can give you things like this, and you have to worry about that. Severe electrolyte imbalance can do it. Drugs can do it. In this case, that's later this morning. In this case, it was ischemia, but you have to think about all those things. What can I treat? What can I reverse? Do you have any tricks to treat acute ventricular arrhythmias? Well, magnesium is a trick you can use if you see Torsade. Some people use it for nonspecific polymorphic VT. The indications for that, I think, is very, very questionable, but it probably doesn't hurt. Beta blockers are very useful. In fact, personally, this is unlabeled. If I'm in a cardiac arrest situation, I defibrillate somebody, they go back into cardiac arrest. I usually don't give them amiodarone. I try first a beta blocker because the refibrillation is often related to high sympathetic tone, and if you can block it, you can stop that. That's unlabeled, unproven, hard thing to do a study on, but try it. Toxicity to class 1 antiarrhythmic drugs, fortunately we don't see that anymore. VT storm, the patient who comes in and has 5, 6, 8 episodes of VT in a day. Beta blockers are both useful primarily and useful as adjuncts, so always think about beta blockers. Torsade, if you have bradycardia-dependent arrhythmias, you can speed up the rate with isoproterenol. Pacing, if you have bradycardia-dependent forms. We also use anti-tachycardia pacing. That's hard to establish unless you know what you're doing, but so many people have devices in that it's sometimes frequently helpful. IV amiodarone, I like to use for recurrent VT or VF, and for incessant VT, the person who just stays in VT. Amiodarone may get you able to get it under control. And catheter ablation, it's actually primary therapy when VT occurs in the normal hearts. In its primary therapy in a specific situation called bundle branch reentry, which you'll probably never see or never recognize if you see it. VT after MI can be treated with catheter ablation, and rarely there are people who have the same PVC that triggers repeated episodes of ventricular fibrillation, and if we find that trigger and ablate it, they can get managed with other means. But this is rare and all requires very specialized help. Drug therapy. Some people say, most electrophysiologists will say, I never use an antiarrhythmic drug. And that means that most electrophysiologists lie all the time, because we use them all the time, but we don't rely on drugs for primary therapy a lot of the time. So for drug therapy, for sustained VT-VF with ventricular dysfunction, we use drugs to modify the frequency and severity of episodes. We often think of defibrillation, ICD therapy, as the primary chronic option. But there are some people who are sick, who don't have a chronic need, and you'll certainly use VT-VF. So we use antiarrhythmic drugs to buy time to stabilize a critical patient, but we have to know that all of our drugs are toxic, and we have to guard against toxicity. Treating PVCs is a poor option. Really, we try to ignore them. A lot of ventricular ectopy we see is the marker of other things, decompensated heart failure. Leave it alone. Don't try to treat this as an endpoint. Sometimes, you're having hemodynamic problems just from the ectopy, and suppressing it is worthwhile, but again, that may not commit you long term. Look for the underlying cause. Beta blockers, ACE inhibitors, always think, is the patient being treated appropriately otherwise? Because those are things that are important, and you really want to look at those, particularly for long-term survival. Now let's move into defibrillators. This is the diagram of a defibrillator. There's a lead that comes down into the heart. There are both pacing electrodes and shocking electrodes, usually two, but maybe only one. This is the defibrillator, which in most people sits in a prepectoral pocket up in the shoulder. This is really a lot of things in here. There are capacitors, a battery, computers, and electronic circuits which allow us to program the device. They used to weigh a lot. They've gotten much smaller now. You can get them down in the 30 cc size. The battery in a defibrillator is different than a pacemaker battery because it has to charge up very frequent to deliver a high energy shock as well as provide pacing therapy. So it's a different type of chemical reaction. The generator is titanium. There are leads that go down into the heart, and you can have atrial and leads to both ventricles. You can have pacing and sensing off of those. The can is part of the defibrillation circuit. There are still a few patients who have epicardial patches on. Those cause some problems, but fortunately they're rare enough that you don't have to worry about them most of the time unless you do pediatrics. Function is they can sense, pace, and shock. They can sense, pace, and rarely shock in the atrium. The devices are supposed to last 4 to 9 years, but it's a function of how much you use them, and they are wildly expensive. This is just the list price for a defibrillator. Do they work? Well, there's two ways of looking at it. If you take people who've had a cardiac arrest or VT and been resuscitated, and you randomize to the best antiarrhythmic drug, which is thought to be amiodarone, and compare mortality to an ICD group, yes, there is better survival with an ICD group, but notice that the mortality is still pretty high. However, the pattern of mortality changes, and a rhythmic death due to recurrent cardiac arrest or VT, is much lower with an ICD than it is with amiodarone. In particular, if your ejection fraction is bad, if it's less than 35%, the ICD is much better than amiodarone. If it's better than 35%, in fact, drugs often give you a second chance. In this study, many patients actually crossed over, but they crossed over only after they survived a second episode. What about the person, it's hard to improve survival in somebody who's already died. And we know that the first arrhythmia people have is often outside the hospital and often fatal. So can we use drugs or devices to do what's called primary prevention? Take somebody at risk for sudden death, treat them with a drug or a defibrillator, and therefore decrease their mortality. Well, unfortunately, almost uniformly, drugs don't do this. This is the sudden cardiac death heart failure trial looking at all-cause mortality. Amiodarone was compared to placebo, and there was no difference in mortality if you treated people with amiodarone. You did decrease mortality with an ICD. However, notice that mortality was still pretty high, and even though this is highly statistically significant, there's still a lot of deaths, even in people with an ICD. However, when I talk to people about getting ICDs, I say, if your ICD goes off once every 2 years, you'll be delighted, because it was worth getting it, it's worth all the hassle, it saved my life, that's great. If it goes off every 2 days, you are not going to be a happy camper. And so we often use drugs to decrease the frequency of ICD use. This is a study that looked at beta blockers alone, sotalol as an antiarrhythmic drug, beta blockers plus amiodarone, looking at the frequency of shocks, and notice that they were able to decrease the frequency of shocks after the loading period to about 6%, as opposed to the people just on beta blockers, it was 33%. So frequently we'll put patients on drugs to decrease shock frequency. It makes the defibrillator better tolerated, and it really is very helpful for many patients. Now, defibrillators cost a lot. There's a big focus on them. So we have pretty rigid criteria. And there are criteria that both come from Medicare services, the CMS, and those are the only ones that really matter in the United States, because that determines whether you're going to get paid for it. But there are also guidelines from societies that we can talk about. They overlap to some degree. They're not exactly the same. For the CMS updates, which were now about 5 years old, it's anybody who has secondary prevention, meaning they've had sustained VT, cardiac arrest, or syncope. And then for primary prevention, there are certain high-risk conditions that are thought to justify a prophylactic defibrillator implant. And those are inherited conditions, usually either coronary disease or ischemic or non-ischemic dilated cardiomyopathies with low ejection fractions. If you think you have somebody in class 4 heart failure and you can improve that to a lower heart failure class with resynchronization, that's an indication. And at the present time in the United States, if you put in primary prevention implants, they're being followed in a national database. When can't you or when should you not put an ICD in? Well, if somebody's in shock or is hypotensive in sinus rhythm, shocking them a few more times isn't going to help you. There's considerable concern that people who get revascularized may improve. So you have to wait and remeasure after 3 months after revascularization procedure. There are 2 studies now, the Dynamite and not shown here, the IRIS study, showing that if you put a defibrillator in somebody who's had a myocardial infarction within 40 days, you get no benefit. So you have to wait 40 days. Always think about revascularizing people. If you have irreversible brain damage, then you probably shouldn't get one. And then there's this rubric, concomitant disease with less than 1 year likelihood of survival. That is a code. No one can predict who's going to survive a year, but that means if they look too sick to benefit, don't put it in. The guidelines for this were published in 2008. Andy Epstein, who's now at Penn, was the leader of this group. It was a multidiscipline group with people from both heart failure and cardiology, so it's a broadly based group. And if you're interested in the guidelines, it's a big issue now. Even as we go through healthcare reform, there's going to be a huge focus on defibrillators, and it's really a critical issue that you have to be comfortable with it. Now, how do defibrillators work? Well, the primary thing is the defibrillator measures rate. If you're too slow, you get treated for bradycardia with pacing. If you're right in the middle, if you're normal, you get no therapy from the defibrillator. If you're too fast, we can treat that rhythm, and we can treat it very aggressively with DC shocks, or we can use various pacing modes and various other types of shocks to try to terminate the arrhythmia. We can also use the defibrillator to diagnose what happened. You know, when defibrillators first came out, somebody would go, oh, I was walking along and pow, I got it. And we never knew what happened. You know, we said, oh yeah, it saved your life. And we found out later it didn't frequently save their life. And so what they built in about 15 years ago is the ability to store the electrograms from an episode, and so you can analyze it. So in this situation, we have an atrial electrogram, a ventricular electrogram, and a second type of electrogram that looks sort of like a ECG. And you can see we're in sinus rhythm here. We stay in sinus rhythm in the atrium, but the ventricle goes into VF. We get a shock, and we're back in sinus rhythm over here. And that would be exactly what we'd want to know. Unfortunately, at least in many series, at least half of the shocks that are delivered are so-called inappropriate shocks because they're delivered for rhythms other than VT or VF. In order to know that, you have to be able to interrogate the device. Guidant has now been bought by Boston Scientific, and last month they changed their programmer screens. So this isn't the programmer screen, but this gives you an idea. You get a screen, you put the programmer over it, you get a little button that says select pulse generator, or something that says quick start, and then you get a screen like this, and you get lots of different parameters, and you get all this stuff. If you don't know what you're doing, it's nice to know how this is set, but please don't change anything. This is another thing. You can print this out. There are very extensive amounts of information here. All of them have some relationship to the therapy, and you really have to be quite expert in doing it. This is the screen you get with Medtronic devices. You have to choose between pacemakers and tachyarrhythmia devices, and then you get a screen of which one it is. Again, if you hit auto-identify, it will do it. And then you get a different looking screen with different terminology that means the same as the prior screen from Boston Scientific, which is still different than Biotronic and is still different from St. Jude. So you really have lots of problems. This is all proprietary stuff. It's very difficult to manipulate this, but you should know the basic functions. Whoops. And the problem is, this is part of a 14-page printout that you get. And I don't even know what some of these things are. You know, I mean, there's all this stuff here. Some of it's important, some of it's not important, but all of it is programmable and all of it is data that you get out of the device, and it may or may not be important for your patient, but you should know what it's basically set at and what it's going to react to if you have an arrhythmia. Lots of things you can get from information. And particularly the intensive care unit, one of the problems we see is somebody comes in with a defibrillator. You say, oh, gosh, they're protected against VF, but actually their biggest risk is atrial fibrillation. And remember that the defibrillator senses rate for the most of the part, and if you have rapid atrial fibrillation, it will probably treat it like VT. And so here's somebody who was in the intensive care unit, went into atrial fibrillation. This is the atrial electrogram. This is atrial fibrillation. The ventricular rate here, it's irregular. Anybody could tell on a cardiogram that this is atrial fibrillation, but it was in the VT zone, so you see these things down here that say VT1. That means the device is going to treat this like VT, and it may make things worse. You can also send people off to the operating room and their defibrillators on. Remember, the defibrillator is just counting electrical activity, and if you try to bovie something, you get signals like this. Well, that thinks oh boy, that's VF, I better charge up and shock that. And so you'll get people who get charged, and that's why you have to have a program if somebody's sent to the operating room to either inactivate or reprogram your device to take care of cautery that occurs in the operating room. There's lots of things that interfere with defibrillators. This is a table of electromagnetic interference, EMI. You don't have to, not too much arc welding goes on in the intensive care units, even though there's so much hospital construction now, I sometimes worry about it. But all sorts of things can affect this, various cellular phones, DC shocks, ECT, lithotripsy, MRs is a big issue, radiation therapy, TENS units. All of these things can interfere and can cause you to have problems, and there's lots of these devices in the ICU, and you have to be careful about that in terms of doing things. So, in fact, I think the biggest choice is, if somebody has an ICD and they're in my intensive care unit, do I turn it on or do I leave it on, or do I turn it off? Well, if you leave it on, you have to worry about atrial arrhythmias, so you may want to change your VT zone. You may worry, even sinus tachycardia may get up to the rate of VT in somebody who's very ill. You don't want to treat that. One of the things that we'll see is we'll see people and they're sick and they're electrolyte imbalance. They have lots of short runs of non-sustained VT, and even though they never get a shock, the device charges. And I had one patient who came in, got charged 113 times in one night, never got a shock. No one ever appreciated it. He had a 3-week-old defibrillator that had to be replaced because he was sick with sepsis. Shocks are painful, and you can't time them. The defibrillator doesn't wait till you pass out. In metabolic abnormalities, the QRS can widen, and you can get double counting. So you can be in sinus rhythm and get shocks. Prolonged resuscitations become complicated because you never know what the defibrillator is doing. Electromagnetic interference is important. And the big thing is, however, that you don't have to worry about somebody getting transferred out of your unit in the middle of the night, put on a floor bed, and dying without his defibrillator on. So most units at least modify their programming but leave the defibrillator on. If you turn it off, it may take you longer to shock for VF, and you do have to worry. The worst thing you do is you actively turn it off, and then sends somebody for a scan or an angio or something, and they die on the way there because you thought their defibrillator was on. So you really have to know what's my skill level, how much help is available, and you really have to know what the device status is. Now, a lot of people will say, well, I can put magnets on, and magnets are helpful. The problem is that magnets can do a lot of things to defibrillators. When they're on, they inactivate sensing, and they always inactivate sensing, and they always inactivate tachycardia functions unless you've happened to program that off. And you don't know that unless you have a programmer. These are the 3 major manufacturers in the United States. Guidant now is Boston Scientific. Guidant devices, sometimes you can program the magnet response off. St. Jude devices, you can program it off. Medtronic devices only responds while the magnet's on. Unlike a pacemaker, you don't change pacing with a defibrillator when you put a magnet on, so bradycardia pacing remains on. If you really want to know, this is the company's statements about their response to magnets. I can't even understand all this stuff, and I'm not sure. I get more confused every time I read it. But in general, a magnet turns off the sensing and the tachycardia functions. Suppose somebody gets a shock. What do you do? Well, you really want to know, for anybody who has an ICD, what's the make, the model, why did they get it, and how long has it been in there? If there's a single shock, no sequelae, you don't have to do anything acutely. If there's a single shock and the patient injured to themselves, well, can we tune the device or add a drug? You probably need advice. If there are lots of shock and they stop, you've got to interrogate the device and see what happened. If there are multiple shocks ongoing, and I assume the patient's on a monitor, if they're for VT, well, keep going. If they're for something other than VT, stick a magnet on it and then call for help. If you see anything wrong with the pocket, call for advice. Never stick a needle in a defibrillator pocket. And the beauty of defibrillators is that they're designed by engineers. I'm insulting some engineers in the room, I'm sure, but there are all these beeps or warnings, and that means something's happening, but it can be anything as, by the way, next Tuesday you have an appointment with your doctor, to this is going to blow up in a few seconds. And you're really, without a programmer, you can't tell. And it's really, and most of my patients can't hear. So that, unless they think it's their, it's amazing. I thought it was my hearing aid until the lady at the checkout counter said, "What's that noise?" It's amazing. Well, should we ever not use defibrillators? Yes. If you have somebody who is going to die anyway, shocking a few extra times probably isn't a good idea. And so this is Lynn Warner Stevenson, one of the most foremost heart failure doctors in the country, and she says we really have to be careful who we put them in. For example, here's a patient, had a pacemaker, had syncope, We interrogated the pacemaker because they have the same functions, and we saw they had polymorphic VT. It had stopped by the time she got there. Clear cut, secondary prevention, indication for a defibrillator, right? Well, she was 101 years old. She had dementia. Should she get a defibrillator? We chose not to. And speaking with her family, they chose not to as well. And I think that was the right decision. So you have to look at the patient. And in fact, there's sort of a sweet spot. This is a study. This is the multi-center automatic defibrillator implantation trial, the second version of it. And they identified risk factors for benefit from a defibrillator. And what they took was your New York Heart Association functional class, whether you had atrial fibrillation, whether your QRS was wide, how old you were, and whether you had modest renal dysfunction. And they looked at those and they said, well, what's your hazard ratio if you have those? And then they looked at it. If you had none of those risk factors, even though you met criteria for defibrillator implant, you got no benefit. If you had more than 3 of those risk factors, or if your BUN was over 50, you got no benefit from the defibrillator implant. It was sort of this sweet spot in the middle where you're just sick enough that you overcome the complications of the defibrillator, but not too sick that the defibrillator is just shocking you repeatedly, that you get the benefit. It turns out this is a large number of people, but it's the biggest issue that we have to deal with as we go over time, dealing with comorbidities. What's the implication of putting a defibrillator in? Well, one of the biggest things is, can they drive? You know, when I go to my clinic and I'll see somebody who has a defibrillator and I know they came from 90 miles away and they're by themselves, my guess is they didn't walk. And so you have to be careful. In New York, they can take the subway. In Virginia, there is no public transport, essentially, so you really have to do that. But if they have a commercial license and they get a defibrillator, even if they've never had a symptomatic arrhythmia, they are totally restricted from that. Now, as I fly home, I'm glad about that for pilots' licenses, but if you have somebody who's a UPS driver and has heart failure but is doing okay, think twice about putting a defibrillator in them. End-of-life issues. This is really important for anybody in intensive care units. And a recent guidelines just was published in Heart Rhythm this May, and some of the things you should read. Remember that if you have a defibrillator or a pacemaker, competent patients or their legally defined surrogate decision makers can have the right to refuse treatment or request that their device be turned off. If it's properly requested, it's not physician-assisted suicide or euthanasia. Patients should be encouraged to have advanced directives. There are several things that people in hospice who have defibrillators often still have them turned on, even if they're in a hospice. However, people can refuse treatment, but they can't demand mistreatment. We get asked periodically, I want you to take it out. Well, that's a surgical procedure. There's risk from it, so we can turn it off, but we rarely will remove it. The guidelines allow physicians and staff to decline to do it, but you can't abandon the patient. You have to, if that's a proper request, and maybe you've had it reviewed by the ethics committee at your hospital, you should get somebody to turn it off. And one of the other thing is, we often get, he's too far, he's DNI, turn off his pacemaker. Well, the problem is, a lot of times, even though we say the patient is pacer dependent, there's some underlying rhythm, and it still may take the patient days to die, so you really have to be careful about that. I actually usually tell people having the pacemaker on makes their patient easier to manage. Eventually, the pacemaker will just stop capturing. What do you need to know about pacing? These are my last couple of minutes here. It's not really VT, but you need to know when to initiate pacing, what the basic modes and functions are, and can you analyze a pacemaker strip. So the simplified indications for pacing are if your heart rate's too slow and you have symptoms and they're related to the bradycardia, pace. Class 2 is, well, your heart rate's slow, but I'm not sure if it's causing your symptoms, but maybe it's associated with a high risk of progression, then you're allowed to pace. and then your heart rate isn't slow and you don't have any symptoms, or the symptoms aren't related, then you obviously don't have an indication for pacing. When we talk about pacemakers, we remember we have a pacing mode. The first letter is the chamber paced, and it's either A, V, or both. The chamber sensed, V, A, or both. And then the response to sensing, whether you trigger a pacemaker stimulus in response to a sense event or you're inhibited. So we have things, or you do both, where you trigger in the ventricle after you sense in the atrium. So those are the things, and you should just know the basic types of things. If you inactivate any of these things, you'll see an O in the pacemaker mode, and that's what we sometimes do if we inactivate somebody who's going to be sent for an OR where Bovie will be used or cautery will be used. Now, how do you evaluate a pacemaker patient? Again, know the patient, cardiac and non-cardiac diagnosis. Has he been exposed or will be exposed to anything in the environment or EMI? And you can change the way the pacemaker is set. Very confusing how to analyze it, so you need a programmer. You have to know something about the pacemaker. Even just to activate the programmer, you have to know who made it. So you need to know something about that. And then you have to know something about the leads, because these are devices that can fail. And you have to consider that, is this a high failure mode or a low failure type of device? And we get calls about this all the time, and there's enough in the literature and the newspapers about recalls. We'll say, oh my gosh, my device is failure, it's on a recall. Well, we can't take them out very easily, so you have to know a little bit about what the risks are with each type of failure. Okay, so what is this? Let's see how we analyze things. Well, it's just like any other arrhythmia. Let's first identify the QRS complex, and we can see that there are 4 wide QRSs that are associated with a pacing spike. There is a narrow QRS that is not associated with a pacing spike, and then there's a pacing spike which isn't associated with a QRS. So what can we diagnose here? Well, we only see spikes associated with one chamber, so we guess it's single chamber ventricular pacing. We look at the atrial or activity on the rest of the cardiogram, and it looks like it's atrial fibrillation. We don't really see discrete P waves marching through here, so we guess it's AF. We see a pacing spike where there's no QRS, so that probably means we didn't capture. And then we see, so the diagnosis would be VVI pacing, underlying atrial fibrillation, intermittent loss of capture, and this is a junctional escape beat. And when you see abnormalities on the pacing stuff, that's the process you should go through. Well, suppose you see a failure to capture. And this, all I'm saying now, applies to both temporary pacemakers and permanent pacemakers. Well, if you fail to capture, did the lead dislodge or get malpositioned? And this can happen with new implants, temporary wires. Trauma can dislodge a pacing lead. You can have high capture thresholds. Did the lead, there's scarring that occurs around the lead tip. We call it maturation. Myocardial infarction can do it, even though that's quite rare. Certain antiarrhythmics in high doses can cause pacing thresholds to change. You have to worry a lot about hypoxia and electrolyte imbalance. Severe hypoxia, acidosis, hyperkalemia can produce big effects on refractory periods. This is oversensing, and we'll see that there. And I'm going to move through quickly. What's happening here? Question, is this ventricular loss of capture, ventricular oversensing, atrial or ventricular loss of capture, atrial loss of capture, or atrial oversensing? Okay, so almost everybody got it. We see it's dual chamber pacing. We're capturing the atrium. We then have a pacing spike associated with the ventricle. We don't see a QRS complex, so this is ventricular loss of capture. If it was oversensing, we'd see no second spike. If we lost capture in both, we wouldn't see a P wave. If we atrial, we said is the function there is normal. So most of you got that right. What about here? This is the morning after a pacemaker implant. Ooh. Okay. Well, atrial spike, ventricular spike, P wave, QRS, atrial capture, ventricular capture. Atrial spike, capture, ventricular spike, capture. Atrial spike, capture, there's a P wave there. No ventricular spike, so the ventricular spike is inhibited. Why would it be inhibited? Because it sends something. Then we go back here. So what this is atrial pacing and intermittent ventricular oversensing. It's not, we're pacing the atrium, so it's not atrial tracking. There's no spike here to capture the ventricle, so we can't expect it to capture. So this is atrial pacing, ventricular oversensing. How do we handle that? So the answer here really is 5, not 3. Again, some practice guidelines. The device-based therapy in 2008 was really a very good thing for this, and be happy to answer any questions. Thanks.